Hi, we're back, day 14 of the 33-day video challenge, and today is all about built environment. I'm Dr. Lauren Kaczynski, and I've been talking through this series just to sort of reframe it again, to think about what causes us to hesitate when we get to a threshold of considering some new ideas or new ways to approach, well, really anything, but here I've been talking about being a doctor, how we conceive of this work. And so I've been retracing, really working mostly from the origins of a rupture that happened 10 years ago that made me stop and reconsider where I was in my career and what I wanted to finish in the time that I had left. And I thought that telling some of this process, which is messy and a lot of it is difficult, might also provide some insight into what you could anticipate and what sorts of obstacles and discoveries you might make in taking this on yourself, which would look completely different from mine, but is nonetheless maybe encouraged by saying, oh, so all of these things can happen and you keep making adjustments and really you just keep going is the motif, I would say, overall. So about built space, there's so much to consider, and so all I'm really going to try to do in this short video is to whet your appetite and to give you some ideas about a little bit of work that's been done. I'm sure there's more that's been done. I haven't been looking at it as closely in the last couple of years. But when you think about the space that we're operating in, and again, this has to do with this idea about what relationship are we in with other people, but also in the built environment that we're trying to function in and do this very interesting but difficult work. And so just as an example of some of the kinds of things that could be considered in this are the size of the space, what it's like to move through the space, how convenient things are, how difficult, appropriate, or inappropriate it is for the activity that we're conducting there. Things like lighting, things like acoustics, things like what we see, and whether that's what the representations are in what we see. Do we see nature? Do we see abstract things? Do we see blankness? Do we see more constructed spaces? What's on the floor? What's the air quality like? What's the light like? Is there natural light? Are there ways to adjust the lighting in the room either for tasks or to encourage certain kinds of thoughts or feelings or activity? There's so much that could be done. And we're so utilitarian, but in a way that's almost in the category of what physician and author Victoria Sweet calls inefficient efficiency, that we don't really have an idea about what the consequences are of some of the decisions that are made about what the built space looks like and feels like. So some of the examples when I first started to look at this were I read an article in the New York Times about a newly opened hospital in Princeton, New Jersey, where they had tried to incorporate some things into the building that were healthier. So we all know about problems like bad air filtration systems and infections or other noxious materials that we can be exposed to in the workspace. Things like carpets or upholstered things that can off-gas and create difficulties or reactions to some of those things. But they were also looking at things like antimicrobial flooring that wasn't just cleanable, but had some properties or things in the material itself to help fight infection. They also looked at organizing spaces so that each of the patient care rooms had the same layout, so that if you were responding to a code, for example, in a room, there wasn't going to have to be a refiguring out of what was where in the room. There was some uniformity so that the practitioners in responding could respond more efficiently. That there was adequate lighting, task lighting. Sometimes that's been a problem responding to codes and things in rooms, that you can't really get the room light enough to do what you need to do, or to do procedures or examine things in the room. It's often difficult. So they also had some ideas, if I remember right, about organizing things to favor reach for people who are right-handed, since that's the dominant handedness. You can agree or disagree with that, but it's just an interesting thing to put into the mix. So that was one thing. Then I started to read things about what do you look at? What's the impact of what you see? So there were studies that were done, for example, about shortening hospital stay and decreasing pain score for patients after cholecystectomy who were put in a room that had a view onto a tree-lined or street or a park versus those who had a room that overlooked another wall. Along the same lines about affecting perceptions or experience of pain, in a study of women undergoing breast surgery for cancer, if they were shown, the group was divided into three different treatments. So you got to see in the preoperative area either a blank canvas, all of these of the same size, an abstract art form, or a scene of nature, a painted scene of nature. And those women who viewed the painted scene of nature before going into the operating room had a statistically significantly lower pain medicine requirement. In another experience, which wasn't exactly a study, but in a cancer center, that the patient rooms overlooked the roof of a neighboring building or a part of the same hospital structure. And so with a grant that had been made, some kind of modernistic sculptures of birds were commissioned and then placed on this roof. And a lot of the patients in the room started to have problems with anxiety or dysphoria. And when the birds were removed, that resolved. So it becomes clear that a lot of what we see can influence our feelings about things and even our experiences of pain and so on. So similar findings were made looking at nursing perspectives or things like fatigue level or sense of positive attitude about the work was definitely improved when the charting area included a window with ambient light, with outside light. So these are important things. I started to also read things about the influence of light on things like dementia. There's some data about being in bright light for a period of time in the day, helping to improve dementia in facilities where people are being cared for with that. Well, by extension, it would make sense that being able to alter the lighting in a room in ways that were appropriate to where somebody was in their phase of care. So, for example, if you want to encourage somebody to not be in bed and to be sitting in a chair, to make an appealing light configuration that invites somebody to the chair might be another way of achieving that rather than just forcing them out of bed. This sense of space and accompaniment by family members and friends, there was a study that looked at having even a portion of the patient room carpeted translated to more frequent and longer stays by visitors, something that was felt to be important for patients' recovery. And again, the things that we have to look at are things like pain medicine requirement and length of stay are a couple of important things. So when we think about being in an environment where we have no connection to the outside world or where the circadian rhythm is completely disrupted because there is no connection to the cycles of night and day in the exterior, also affect us working in those environments. And in fact, now there's an association between night shift work and breast cancer, increased breast cancer incidence, enough such that in some countries, nurses who get breast cancer, who've worked night shifts, are eligible for workers' compensation coverage for their breast cancer care. Yeah, it's pretty amazing. I mean, we're aware of other things that we have exposures to in our line of work, like inhalational gases and things like that. But there's a lot about our environment that could be addressed consciously to try to improve patients' experience, visitors' experience, and our own experience, our own well-being in the space. Recently, I had an elective operation here in Switzerland, and I was astonished that in my shared room, my bed was near the window and that the window opened. We just had a foot of snow, and it was fresh and beautiful outside. And the blankets on the bed weren't these threadbare, washed 1,000 times blankets that I'm used to seeing in US hospitals. There was a duvet with a cotton duvet cover, so it was possible to be snuggled in bed and to have a room that was fresh and felt connected to the outside. It's quite amazing. So these are some of the things that I want to say about our built space and what we try to function in. And it's almost seen as, again, a sign of weakness if you're flagging, if you're failing, if you're worn down by what are really not very conducive environments to our own well-being, our patients' well-being, or even to fostering making connections in that space. And this both happens on the technical level of how, with what ease or difficulty there is to navigate the room and to get done what we need to get done, and with things that are responsive to the full range of our sensibilities in ways that support our integrity, support the wholeness of our experience in a place that we spend an awful lot of time. I guess I'll just add one more vignette, which was that in New York City, the issue of wayfinding and of access to stairs and green space was taken on as a public health initiative. And we don't have a lot of ways in hospitals to encourage us to use the stairs, to have wayfinding for the stairs, because even going up and down a couple of flights of stairs several times a day is good exercise for us when we're in that space, and for other people as well. But generally the stairs are cut off, or they're signed in a way that you could get in and not be able to get out, or set off an alarm. So this is just a further example of a kind of thing that can happen in built space that addresses our well-being. I'll see you in the next video.